simplest way, the damage is rarely contained. The escaping corrosive fluid systematically degrades everything in its path. In human anatomy, the lower esophageal sphincter, or LES, serves as a critical one-way biological check valve. It allows food to pass down into the stomach while actively blocking gastric contents from coming back up. This diagram illustrates when that biological seal degrades. As the sphincter weakens, gastric fluid breaches the barrier, flowing directly into the esophagus. This refluxate combines hydrochloric acid with pepsin, exposing the lining to a harsh chemical environment it cannot tolerate. When this mixture makes contact with the esophageal lining, the tissue experiences immediate chemical burn and acute cellular trauma. The stomach is coated in a thick, specialized layer of mucus designed to withstand this exact harsh chemistry. The lower esophagus lacks these defenses entirely. Repeated exposure to these corrosive agents triggers a progressive cascade. What begins as superficial surface inflammation forces the local tissue to attempt drastic, irreversible remodeling just to survive. As the body tries to heal, ongoing chemical burns, scar tissue blocks the tube, or cells mutate dangerously. A mechanical valve failure triggers a chronic biological progression, where the body's attempts to survive chemical injury eventually compromise the organ's function. To understand how this damage accumulates over time, we have to look past the organ itself and observe the actual surface of the mucosal lining. This section of the diagram shows the macroscopic acute response to exposure. The repeated acid wash creates localized edema, severe swelling, and burns away the top layers of tissue, forming deep superficial ulcers. However, a precise diagnosis of the injury's severity requires a histological view, examining the microscopic cellular markers within the tissue wall itself. When cells are forced to divide at this unnatural speed, they are highly prone to copying errors. If the reflux remains untreated over months or years, the acute cellular response inevitably forces a permanent structural change. The sheer volume of repeated, deep ulcerations eventually exhausts the mucosa's capacity for normal, healthy regeneration. To patch the escalating damage, the body relies on its default, blunt force mechanism for deep tissue destruction, fibrosis. This top panel illustrates healing via fibrosis. Instead of replacing the lining with flexible, healthy mucosa, the body lays down thick, rigid scar tissue. Depositing rigid scar tissue inside a circular, tubular organ has immediate physical consequences. The dense fibers pull inward as they heal. This inward contraction creates an esophageal stricture, resulting in a permanent physical narrowing of the internal opening, or lumen. Clinically, this stricture causes severe dysphagia. The mechanical tube becomes so constricted that patients experience acute difficulty swallowing solid foods. The body successfully patches the chemical wound, but the resulting scar destroys the organ's primary mechanical ability to transport food. While strictures create a mechanical barrier, a second chronic pathway involves a microscopic strategy for survival. Under normal conditions, the esophagus is lined with squamous epithelium. These flat, delicate cells are excellent for allowing food to slide down smoothly, but they are entirely unequipped to withstand a chronic bath of digestive acids. Faced with persistent trauma, basal cells change their differentiation pathway, replacing the lining with a completely different cell type, intestinal metaplasia. Flat squamous cells are replaced by intestinal-type columnar epithelium, equipped with specialized cells that secrete thick, protective mucus. The tissue effectively senses the highly acidic environment and mimics the naturally acid-resistant lining of the intestines to survive the continuous onslaught. This precise histological transformation, clearly visible in this panel showing the distinct columnar cell structures, provides the definitive diagnosis of Barrett's esophagus. The adaptation engineers a highly effective shield against the stomach fluid. However, this fabricated tissue is microscopically unstable and prone to further mutations. The shield that Barrett's esophagus provides comes with a severe long-term penalty. Forcing cellular structures to rapidly divide and exist in an abnormal metaplastic state creates a highly volatile genetic environment. This instability leads directly to progression to adenocarcinoma. the tissue loses structural order, multiplying into a disorganized, malignant mass. Patients with long-standing Barrett's esophagus carry a drastically heightened risk. It is the most significant clinical precursor to developing this esophageal cancer. The pathology follows a linear progression. It begins with a mechanical failure of the lower esophageal sphincter, initiating mucosal injury. Chronic damage diverges into permanent maladaptations, stricture, or Barrett's esophagus. Both represent a failure of regeneration, ultimately carrying the risk of adenocarcinoma. Yet this entire biological cascade follows a strict sequential timeline that can be halted. Interrupting the progression requires early detection, medical control of the initial reflux, and routine monitoring of chronic symptoms. Reflux esophagitis is a progressive, predictable timeline. A mechanical anatomical weakness will steadily progress toward malignant cellular reprogramming unless medical intervention breaks the cycle.